A very good evening to all of you. I welcome you all for the third academic activity of the Epilepsy SIG. And today I have an interesting talk on update on overview of neonatal seizures by Dr. Lakshmi Nagasan from Australia, Perth. I request our President, Dr. Shipali Gulati, to introduce the speaker and our today's moderators for the session. Over to you, ma'am.
Yeah, thank you. Thank you, Mahesh. And thank you all of you for joining this very important session. And I know you have detractors in the form of Bhaiya Dooj and the big match going on in the background, which you can put on recording maybe and watch after this session, this amazing session. And today the topic is going to be on neonatal seizures update. Mansi, can I have the CV slide of Dr. Lakshmi? Dr. Lakshmi is Secretary, International Child Neurology Association, a child neurologist, epileptologist in the Perth Children's Hospital, Australia, and clinical lead, epilepsy and neurophysiology, clinical professor, UWA Medical School, and area of interest is neonatal seizures, neonatal neurology, epilepsy, neurophysiology, and overall child neurology. And we are really grateful that she has joined. It is pretty past dinner time there in Perth. Thank you so much for joining, Dr. Lakshmi. And as we have in this year, we started having talks with two experts, a talk by a very senior pediatric neurologist, and then experts. Today, we have experts, Dr. Suresh Pujar, who is consultant pediatric neurologist at the Great Ormond Street Hospital for Children, UK, and is an honorary lecturer at the University College of London, UK, and is a chair for British Pediatric Epilepsy Group and chair for UK Pediatric Epilepsy Program Board. And his areas of interest are status epilepticus, virus, Rasmussen syndrome, complex epilepsies, epilepsy surgery, ketogenic diet, and transitional care. And the other expert we have is Professor K.P. Binayan, and which I believe nobody needs, he doesn't need any introduction, but he's professor and head of pediatric neurology at Amrita Institute of Medical Sciences, Kochi, and he's member of the Commission of Diagnostic Methods, International League Against Epilepsy, member of the Asian Epilepsy Academy, and a member of the EG Neonatal Seizures Research Advocacy Task Force, and convener of he's now the chair of the Pediatric Neurology subsection of the IAN, and he's currently the secretary of the Indian Epilepsy Society. And I think this will be an interesting talk, and we have our moderator, who is going to be Dr. Sandeep Patil. Actually, as many of you know, most of you know, that we have made 9 different SIGs, and every month we are giving to one SIG for these Wednesday webinars. And we have a SIG in which we have a convener from the EB and one convener who's not in the EB member, and a moderator who is a secretary, who's Ranjit here, and Dr. Sandeep Patil is the convener from the EB, and Dr. Parekh is there. And Dr. Goraya, all of them are there. Dr. Jitendra Sahu is the convener from outside. So Dr. Patil will be moderating today. I can have his slide back. He is working extensively in epilepsy and epilepsy surgery, and maybe having the largest cohort of epilepsy surgeries in India. And so he's a consultant epileptologist and pediatric neurologist at the Dinanath Mangeshkar Hospital, Pune, and running a Apex Advanced Epilepsy Center. So he'll be conducting the Q&A. Right now, I'm sending if you want to say anything, Dr. Patil, to begin with. Otherwise, Dr. Lakshmi can start, and then we have experts and you moderating the Q&A. Dr. Patil?
Waiting to Dr. Lakshmi in Australia. So let's start the talk.
Thank you.
Yeah.
Do you see my screen?
Not yet.
Not yet.
You'll have to click on share screen in Zoom.
Yeah, it worked before. Can you see it now?
Yes.
Yeah, it started. It started.
Yes.
It's not full screen as yet.
Now, any better? No?
Perfect.
Yes.
Yeah.
Manasi, can you make it at the full screen and you remove the presenter mode,
Is that
please?
better?
That's Professor Lakshmi. Just done it.
Yeah.
Thank you very much. It's a privilege to be invited, and I know many of you, and I've heard of many of the others. I'll start the talk now, and I'm going to give an overview of neonatal seizures. As you know, seizures are the most common neurological emergency in the neonatal period and are associated with mortality and morbidity. And they don't easily fit into classification schemes for seizures and epilepsies that have been developed for older children and adults. Therefore, the classification of seizures for neonates has been modified. Electrographic-only seizures are very common in neonates, and most neonatal seizures are acute symptomatic of provoked seizures. Unprovoked seizures are less frequent and constitute less than 10 to 15%. Hypoxic ischemic encephalopathy, stroke, and intracranial hemorrhages are the etiological factors for about 75% of all neonatal seizures. And it's very important to make an early distinction between acute symptomatic seizures and unprovoked epilepsy. If you look at seizures in the neonate, most babies with seizures will follow for one of four pathways. So you have an insult and you have a symptomatic seizures from the insult, and the seizures usually occur in the first 3 days and then settle down. And then majority of babies, nothing more happens with acute symptomatic seizures. However, anywhere between 10 to about 30% of babies after a latent period, usually a median time of about 7 months, develop seizures again and get post-neonatal epilepsy. For some causes of acute symptomatic seizures, like an arterial ischemic stroke, this latent period may be much longer, and the incidence of post-neonatal epilepsy is much higher after having a peripheral arterial ischemic stroke in the neonatal period that the baby presents with seizures. A smaller number of babies with acute symptomatic seizures will never stop having seizures, and they directly evolve into having epilepsy. And then there's a small percentage of babies who have neonatal epilepsies that start in the neonatal period and continue following that. Why are we worried about neonatal seizures if the majority stop? Because we think that neonatal seizures beget seizures. And neonatal seizures increase susceptibility to seizures later in life, both in the animal models, and there is data in the human supporting this as well. People are looking at the mechanisms of secondary epileptogenesis to see if we can modify that. And it is thought that cascades of molecular, cellular, and structural changes are responsible for the epileptogenesis later. There could be loss of GABAergic interneurons. The cation chloride co-transporter ratios are changed in the neonatal period. And in the immature brain, there's a higher ratio of sodium potassium chloride co-transporter compared to the potassium chloride co-transporter. So that chloride, there's greater influx of chloride into the cell. There's neuroinflammation with microglial activation and astrogliosis. And alterations in various signaling pathways have been shown to occur. For example, in the JAK-STAT pathway, the mTOR pathway, the BDNF and the tyrosine receptor kinase pathways, the toll-like receptor pathways. And so they also lend mechanisms by which we might look to alter this pattern of epileptogenesis. The electroclinical and imaging evolution pattern from acute symptomatic seizures to later epilepsy is still yet not known very well. And while we talk about this concept of a latent period, people have brought that into question. And recent data from both animal studies as well as from recordings in the ICU, both invasive and scalp EEG, suggest that they never stop. That they may be like micro or mini seizures occurring in a small part of the brain. And as it sort of becomes bigger and bigger area of the brain involved, then it then manifests as overt seizures. And that is called the process of epileptic maturation. And maybe the ways to modulate that is different from when we thought there was a long latent period of when seizures occur and result in post-neonatal epilepsy. If you look at the seizure classification, this is on your left is the ILA classification for older children and adults, but then the ILA classification of seizures and epilepsies in the neonatal period was modified, and this was published in 2021. It is recognized that all seizures in neonates are of focal onset, And that and there's a new category of seizures which is electrographic only, which is not present in the 2017 classification, but only in the neonatal, the classification modified for neonates. And so you have electroclinical seizures and electrographic seizures, and you have epilepsy syndromes like EIEE, EME, etc. But the other two streams that you do have to look at, like for children and adults. And if you look at etiology, it is recognized that hypoxic ischemic encephalopathy is the most common etiology in most term babies, and is a common etiology even in preterms. Those structural causes, vascular causes may also occur: arterial ischemic strokes, venous strokes, intracranial hemorrhages, and brain malformations may also be a cause for seizures. Then you have genetic causes. Infectious causes in some parts of the world constitute a larger reason for neonatal seizures than in the high-income countries. Metabolic causes may be the cause of seizures, and metabolic perturbances rather than inborn errors of metabolism may contribute to the occurrence of neonatal seizures. And that's that category none of us like, where we don't know why the seizures are occurring. This is another illustrative way of showing the etiologies for neonatal seizures. So hypoxic ischemic encephalopathy still constitutes the most common reason for neonatal seizures, with vascular and infectious causes also contributing. And then there is this group of causes which constitute about 10 to 15% of the etiologies, and there may be overlap between the different etiologies. Another way of looking at it is looking at it as like acute symptomatic seizures, or looking at unprovoked seizures, which may be remote symptomatic. For example, if you've had an ischemic stroke in the antenatal period, but it could also be due to structural causes and genetic causes that are unprovoked seizures. You have the seizures evolving into post-neonatal epilepsies, and you have the genetic epilepsies, which are the self-limiting epilepsies that present in the neonatal period, and the developmental and epileptic encephalopathies, or the DEEs. The self-limiting neonatal epilepsy, the more is important, because usually seizures occur at around 2 to 7 days of age. You can have focal tonic seizures, but you can also have clonic, autonomic, or myoclonic seizures, and they may occur over days to week. And somewhere between 15 to 30% may have seizures later. KCNQ2 is probably the most common gene mutation associated, but KCNQ3, SCN2A, and even SCN1A may be the cause of this. And they often are autosomal dominant, though de novo mutations can occur, and sodium channel drugs are often useful, and we should keep that in mind. The self-limiting neonatal infantile epilepsies, as well as the self-limited epilepsies in infancy, may also present in the neonatal period, and it's good to be aware of the genetic mutations that are associated with these. So if you look at, again, another way of looking at it is by structural etiology, looking at the MRI for brain malformation disorders, for dysplastic lesions in the brain, by genetic etiology, by gain or loss of function mutations. But in the neonatal period, often gain of function mutations present earlier in the neonatal period, infectious or immune etiologies, metabolic etiologies like pyridoxine-dependent epilepsies, GLUT1 deficiency presenting as seizures in the neonatal period, and unknown etiologies. The Eiley classification and definition of epilepsy syndromes with onset in neonates and infants looks at it as self-limited epilepsies, development in epileptic encephalopathies, and etiology-specific syndromes. And this is particularly important to identify because the treatment would be targeted to the etiology. If you look at babies presenting children presenting with seizures in the less than 3-year-old, you can classify the epilepsy by syndrome or etiology in at least 50%. And the younger the age of onset of seizures, the more likely you're able to classify specific etiologies. It is good to look for genetic etiologies, but in many parts of the world, including where I practice from, getting a gene test takes quite a while. We don't have access to it in the acute period. And so we often use electroclinical features to try and decide what the etiology of the seizures is and how we target our interventions for it. So an antenatal history is very important. A neonatal history, history suggestive of perinatal asphyxia is important. A family history of seizures starting in the neonatal period and then being okay is important, and it might direct you towards thinking of a self-limiting epilepsy in the neonatal period. Age of onset of seizures and seizure types is also helpful. The EEG background is very useful, and each unit is often very good at one particular aspect. Some units are very good at all aspects, and you use your expertise in the area to reach an etiological diagnosis and target interventions. The background in the EEG: do you have a burst suppression pattern? Do you have an EEG suggestive of a DEE? Or a dysmetro EEG, a disorganized EEG, or you have lots of brief EEG rhythmic discharges on your EEG. And then you can try and classify your epilepsy syndromes like EIEE, early myoclonic epilepsy, and early epilepsy in infancy with migrating focal seizures. The clinical features also help you. For example, if you've got a baby with a big head and a brain malformation disorder with megalencephaly, and you've got seizures, you might think of mutations in the PIC pathway, or if you have a baby with a small head size, might direct you in another pathway. You look at the tone of the baby is very hypotonic. You might think more of a CDKL5 type of disorder. Is there a movement disorder associated? Is visual attention affected? Does the skin give you any clues? Are there any features to suggest Sturge-Weber syndrome or tuberous sclerosis? So it's a good clinical history is a good clinical examination and history is often very useful. The same abnormality in a particular investigation, or for example, the EEG, the MRI, or a gene, may be associated with different phenotypes. So it's important to correlate the clinical features and the history with what you say. This is a baby who's got a burst suppression pattern that you can see on this EEG, and this baby had HIE. But you can also see a burst suppression pattern, as can be seen on panel A here. This is a baby who has a brain malformation disorder with the left side more affected, and you can see the epileptiform discharges over here being of high amplitude on the left side, represented by the blue color-coded leads. And this is a baby with a non-ketotic hyperglycemia who also has a burst suppression pattern, has an EME. So you have to think of the clinical situation and interpret your findings on that. Now, babies don't read textbooks. So I'm going to tell you a little story about this little baby who was born in a peripheral hospital, was born at term, was good birth weight, and you can see the baby is well grown. This baby was sucking but not feeding well. Baby was a bit sleepy, had a barium swallow because it had some hypopneas associated with feeding. Barium swallow didn't show anything. Now it was getting on to be day 4 and got transferred to a bigger hospital to see if he could work out why this baby was encephalopathic. And this was the EEG on the baby. These are 4 epochs of 10 seconds each. The blue leads represent derivations from the left hemisphere and the green from the right. And you can see that there's a seizure discharge on the left-sided derivations. And this baby was in electrographic status. There were hardly any clinical features. Occasional electrographic seizures had some subtle clinical features in the form of a hypopnea, but most of the time the baby would look like what you saw on that video. When the baby was not fitting, there was asymmetry of the background with reduction in amplitude on the left side, as you can see in these 2 epochs of the EEG, and this baby had a left MCA stroke. Did not present with what you would expect focal clonic seizures on the right side. The baby just presented with electrographic status. And this is this young lady now, 15 years later, and she's happy for her photograph to be shown. She has a mild right hemi, she has mild cognitive disability, but she has epilepsy, which is reasonably well controlled, and she's doing quite well. Now, we've talked a little bit about when you're thinking about a treatment approach to neonatal seizures, prevention of prematurity, small for gestational age is very important. Good antenatal, perinatal, and neonatal care is essential. We've talked a little bit about etiology. I'm now going to move to the importance of accurate diagnosis when you're thinking about neonatal seizures. We'll then talk briefly about anti-seizure medications, neuroprotective strategies, and targeted therapies. There are many challenges in the diagnosis of seizures in the neonate. Electrographic-only seizures are very common and constitute anywhere between 60 to 90% of seizures in most studies. Electroclinical seizures can occur, but in a busy nursery, sometimes subtle clinical features can also be missed. Paroxysmal non-epileptiform events that mimic seizures and are often treated as though they are seizures in studies that go just by clinical features also occur in babies quite commonly. And babies have none of these, may have one, two, or all of these types of events, making the sorting out whether a baby is having seizures or not quite difficult. Now, without neurological monitoring, babies with seizures may remain undetected, and others treated with anti-seizure medications for non-seizures. And acquiring an EEG in a term neonate can be challenging enough, but in a preterm neonate, you have to have qualified technologists to be able to get good studies and therefore make good interpretations. When you're looking at EEG monitoring, you have two types of EEGs that are used. One is the conventional video EEG monitoring, and the other is the amplitude integrated EEG. A lot of nurseries across the world have amplitude integrated EEG monitoring. However, we now know that a continuous conventional EEG monitoring is recommended and considered the gold standard to diagnose seizures in neonates. It's recommended by multiple clinical practice guidelines, systematic reviews, comparative neonatal seizure management. It is imperative that we have conventional video EEG monitoring. International guidelines recommend this for a minimum of 24 hours as the gold standard for picking babies with seizures. Amplitude integrated EEG can be used in addition to a conventional EEG, or if conventional EEG is not available. However, all of us who deal with babies with seizures have to recognize that the sensitivity and specificity of amplitude integrated EEG is rather variable, and it cannot be recommended as a mainstay for seizure detection, diagnosis, and management. We have worked in this area and have shown this, as have many others. And however, in most situations, including in our hospital, continuous conventional EEG is not always available. And therefore, we have to work out what's the best paradigm for where you are working with and use all that you have. We often do conventional EEGs every day and the amplitude integrated EEG as continuous recordings. Because of staffing issues, we cannot provide conventional EEG regularly as continuous EEG for all at-risk babies. The ILA classification of seizures and epilepsies also recognizes that the gold standard for diagnosis of seizures is the conventional EEG. Now, why am I harping on this? Because I think if you do not use conventional EEGs and you look at studies, then the outcome data that you get is very difficult to interpret. We did a diagnostic accuracy study on continuous video EEG versus amplitude integrated EEG, and we showed that there was concerns regarding sensitivity and specificity, especially for individual seizures, and the specificity for even for babies with seizures was only about 50%. But afterward, again, we analyzed the data from this study to look at why neonates receive anti-seizure medications. And of 36 neonates that were monitored for 24 hours with both AEG and conventional video EEG, the conventional video EEG was not available for clinical decision-making. It was analyzed later not blinded to the clinical information of what happened to the baby. Anti-seizure medications were given during the monitoring based on clinical observations by the neonatologist and the amplitude integrated EEGs. 12 of these 36 babies received anti-seizure medications during the 24 hours. Out of those, only 5 actually had seizures on conventional EEG. So 42% of babies who received anti-seizure medications during the 24-hour period did not have seizures on conventional video EEG. Also, there was no correlation, or there was very poor correlation between the seizure load or the epileptic burden and the number of anti-seizure medications that were administered during the monitoring. 6 of these babies had clinical and AEG seizures, and all 6 also had seizures on conventional video EEG monitoring. 3 babies were treated for amplitude integrated EEG seizures only. Only 1 had a seizure on conventional video EEG monitoring, and 3 were treated for clinical seizures. None had seizures on conventional video EEG monitoring. There are studies from several other centers which show that clinical acumen alone is inadequate. Amplitude integrated EEG for monitoring anti-seizure medications and for detection of seizures is also definitely not as reliable or consistent as conventional EEG. The critical importance of EEG confirmation is underscored by the ILAE, and it is recognized that the conventional video EEG is the gold standard for diagnosis. However, the position paper for seizures in the neonate from the ILAE does not, there are certain things that it does not address, and that is conventionally, we all think a seizure, an EEG discharge must have a stop and an end, and that it should last at least 10 seconds in duration to call it a seizure. But the position paper leaves that open. What about brief EEG rhythmic discharges? Again, the paper discusses these, but does not say whether we include them in the epileptic burden or the seizure burden or not. We've talked about acute provoked seizures versus seizures as a manifestation of epilepsy. And the clinical semiology and classification of electroclinical seizures in the position paper is dependent on the most obvious clinical feature, rather than the first clinical feature, which is what is used in the 2017 classification. And I think it's one of the drawbacks of this electroclinical classification, because using the first clinical feature and how the clinical seizure progresses helps us understand the neonatal epilepsy networks. But when in the current classification, we just say the most prominent features, or we call them sequential seizures when we've got lots of features in them. The other thing that the position paper does not address is what is status epilepticus in the neonate. Conventionally, we've always considered it to be electrographic status if more than 50% of a 1-hour recording shows electrographic seizure activity. So it leaves us in a bit of a limbo as to how do we diagnose status epilepticus in the neonatal period. What are brief EEG rhythmic discharges in the neonate? We consider discharges between 5 and 10 seconds duration to be brief EEG rhythmic discharges in the neonates. There are others like Schumann et al. Who consider even less than that to be brief interictal rhythmic discharges or ictal rhythmic discharges, and they've called it BIRDS. And this is just an illustration of a baby who had both brief intermittent rhythmic birds, as we call them. You can in panel A, you can see a run of epileptiform discharges less than 10 seconds duration, but more than 5 seconds, which we call a bird. And then in panel B, you see a prolonged seizure, or at least some of the prolonged seizure. The discharge is more than 10 seconds in duration. They look very similar, and we think they should be considered mini seizures, especially for clinical research trials. Now, we talked about distinguishing between acute provoked seizures or symptomatic seizures and neonatal seizures because of early onset genetic epilepsies. How can we distinguish them clinically? Most seizures in the genetic epilepsies are electroclinical in nature, in contrast with what you see in hypoxic ischemic encephalopathy, where most seizures are electrographic only seizures. Prolonged attenuation after seizures is more likely to occur and is greater in the genetic epilepsies compared to the symptomatic seizures. Most seizures in the genetic epilepsies are short and may not fulfill the criteria of 10 seconds that we've used conventionally to define an electrographic seizure. You're more likely to have brief tonic seizures, clonic seizures, myoclonic seizures, and spasms with the genetic epilepsies, though status can occur in the genetic epilepsies and does occur as well. Seizures with the genetic epilepsies often start later than seizures due to HIE, which often start in the first day, with 80% of the seizures occurring in the first 72 hours in a term baby. A trial of oxcarbazepam, carbamazepine, or phenytoin is warranted even if you think it's a early onset of a genetic epilepsy, especially if you think it could be a channelopathy. I'm just going to illustrate genetic epilepsies with two case reports. This is a little infant we saw in our emergency department in 2019. It came in late one evening, flew in from another country, and came straight from the airport to our emergency department. When the baby got to us, it was about 3 months of age. We did an EEG the next morning, and this is the EEG here that you can see. And you can see that this baby, on the video, you can see the clonic seizures that are occurring. And on the EEG, again, the left-sided derivations are from are color-coded blue, and the right-sided ones are color-coded green. The baby is in electrographic and electroclinical status almost throughout the 1-hour recording that we obtained. This is just another epoch, and this is a 15-second epoch of an EEG. At another time, you can see there's a seizure discharge on the left side, and then there's a different seizure discharge on the right side, and this baby had seizures all the time. This is another 15-second epoch when you can see an electrographic seizure on the left and an electrographic seizure on the right as well. So there were multifocal seizures, and they were not always concordant between the two hemispheres. The history was that the seizure onset was on the first day of life. The seizures, multiple seizure types were seen. Clonic seizures were the most frequent, but tonic seizures, myoclonic seizures were also seen. The baby was in status epilepticus a lot of the time. Baby was very stiff. The baby was quite hyperreflexic, neurologically very impaired, had microcephaly, was nasogastrically fed, had been previously treated with levetiracetam, phenobarb, topiramate, clonazepam, pyridoxine, biotin, and had been extensively investigated overseas with no etiology being determined. A whole exome sequencing was reported to have been done, an epilepsy gene panel was reported to have been done, and these did not pick up any variants of significance. When she came in the late evening, we gave her a phenytoin load, and also then gave her a lacosamide load and gave her some rectal paraldehyde, and decided we would make some long-term decisions the next morning. We discussed the poor prognosis for neurodevelopmental outcome, whatever the cause. And we discussed options of care and decided to treat for comfort, that we would not intubate or ventilate, and that we wish to investigate further for one specific gene that we thought this baby may have had. Anybody? I can't hear anyone answer. I'll carry on. Yes, this baby had a mutation in the BRAT1 gene, and is one of the individuals described in this paper of 97 people with BRAT1 related disorders. The phenotypic spectrum and the phenotype-genotype correlations were explored in this publication. And of 97, there are two types of presentations that you have when you have a BRAT1 related disorder. One, and the more common one, with 59 individuals in this paper out of 97, showing rigidity and multifocal seizure syndrome with microcephaly. And this is called the RMFSL syndrome. Babies usually die in the neonatal period or in infancy. And another one where the phenotype is less severe, where you get neurodevelopmental disorders associated with cerebellar atrophy with or without seizure syndromes. And there's some correlation between genotype and phenotype, though it is not absolute and not very strong. So the clinical features in this baby that helped us think that this is probably what this baby had and made us look again for this particular gene were the fact that the baby was very rigid, was hypertonic, hyperreflexic, had a small head. MRI was normal at that stage, that's why we thought of this. But it could be some other disorder, other genetic mutations as well. But this was what we targeted and found. Now, this is another baby with seizure onset in the second day of life. Parents first reported one seizure. They said one side of the face was jerking. The nurse reported 3 more seizures the next day, and the seizures escalated very quickly. and the seizures were associated with limb involvement, at times hypopneas and apneas, and they sometimes occurred on one side and sometimes on the other side, and they seem to sometimes start on one side and go to the other side. Multiple ASMs were not effective. We did try phenytoin and oxcarbazepine. There was no history of HIE. There was no significant family history. MRI was non-contributory, and metabolic screen did not show any significant abnormality. This was one of the EEGs captured when the baby was, and the seizures which were captured when the baby was about a few weeks. But the baby had seizures all along. And you can see that on this EEG, you can see the seizure discharge. All the EEGs have the left hemisphere derivations are color-coded blue, and the right hemispheric ones are red. You can see the seizure discharge on this EEG on the left side over here. Then it flips over to the right side in the same seizure. And both the ictal EEG discharge as well as the clinical features migrated from one side to the other. And I'm sure many of you have guessed what we think this baby has. This baby has the early onset infantile epilepsy in infancy with migrating focal seizures. The major genes associated are the KCNT1 being the most common, but the BRAT1 gene, sodium channel genes, the TBCD gene, and we've recently had an ATP1A2 gene mutation associated with this syndrome. Mean age of onset is about 3 months, but they can present early in the neonatal period like our baby presented. You can have focal tonic, subtle features, autonomic features. Seizures are often very frequent, and status epilepticus is not uncommon. Usually, you don't see myoclonic seizures. And typically, focal seizures migrate from one cortical region to another within a seizure, and seizures are often prolonged, and status epilepticus is quite common. They are drug resistant. MRIs are initially normal. Over time, they atrophy. Microcephaly usually occurs by 1 year of age. We did try quinidine in this baby. It did not work. It did not have any effect. Prognosis is poor, and there's reduced life expectancy in most. And they're significantly developmentally impaired. When we're thinking of genetic epilepsies in the neonatal period presenting as seizures in the neonate, you have to think that besides seizures, they often have other features, either in the neonatal period or in infancy and early childhood, and autistic traits, cerebral malformations, movement disorders, developmental disability, intellectual disability are not uncommon associations with the genetic epilepsies. And therefore, you need to be able to pick them and address them. The treatment approach to seizures in the neonate has to be targeted, depending on what the reason for the seizures are, and if it is an inborn error of metabolism, you target therapy for that. This is an interesting pilot study which looked at babies with acute symptomatic neonatal seizures who later had postneonatal epilepsy. And they found that they had a higher prevalence of coding variants with the targeted epilepsy gene panels compared to patients who did not develop postneonatal epilepsy after having seizures in the neonatal period. And therefore, this area has to be explored further, but may also help us understand why postneonatal epilepsies occur. Despite all that we know, even when we diagnose, even after we manage to diagnose them correctly, it's still, there's debate regarding what should you treat. Should you treat clinical seizures? Should you treat electroclinical seizures only? Should you treat electrographic seizures as well as electroclinical seizures? Should you not treat clinical seizures? Should you include in your treatment paradigm the brief EEG rhythmic discharges, or in your epilepsy seizure burden estimation, should you include them? When should you treat? Should you treat after the first seizure, or should you wait for some time? We know that timing is critical, and if you start treatment within 1 hour of seizure onset, there's less seizures subsequently and less incidence of status. But when you have the first seizure, do you know what is going to happen over the next hour? Is duration of the first seizure captured important? Is the frequency of seizures important? And when you're looking at neurodevelopmental outcomes or interventions that may influence that, is the epileptic burden important? We know etiology is important, but sometimes we don't know what the etiology is when the seizures first occur. when we look at therapeutic options for treatment of seizures in the neonates, we know they are very limited even today. Frequently used anti-seizure medications are not very effective. There are concerns regarding the safety and adverse effects, both short-term and long-term, including effects on neurodevelopment with all the anti-seizure medications we use today. So some of the data is from animal models, some of the data is human data, but we cannot say for certain any of the medications that we use will not have an adverse effect on long-term neurodevelopment. Under and over treatment may have adverse consequences. We know that electrographic seizures themselves add to the burden of epilepsy and contribute to long-term neurodevelopmental outcomes. Therefore, we have to treat them, but we should not treat them too much, and we should not treat babies who look like they're having seizures who don't really have epileptic seizures. The ILE set up a special task force to look at developing guidelines and consensus-based recommendations for treatment of seizures in the neonatal period, which included neonatologists, neurologists, epileptologists, neurophysiologists, and at least one person who was not in the medical field. And so when we looked at this, we did a systematic a review and meta-analysis. We followed all the guidelines that are required to be followed for a good meta-analysis and systematic review to provide guidelines. And as a result of that, we had six priority questions formulated using PICO format. 6 recommendations were made, and 2 additional considerations were suggested. One was that we have a standardized pathway for management of seizures in each neonatal unit, and also that we inform parents and guardians about the diagnosis of seizures and the initial treatment. Now, what were the 6 recommendations made by this task force? The first one was that phenobarb should be a first-line ASM. This was based on evidence, and that phenobarb should be the first-line ASM regardless of etiology. There was expert agreement on that. Unless channelopathy is the likely cause of seizures because of the family history and the seizure profile and the EEG and MRI if the baby's had one, in which case phenytoin or carbamazepine should be used. The second recommendation was that among neonates with seizures not responding to first-line ASM, phenytoin, levetiracetam, midazolam, or lidocaine may be used as second-line ASM. This was based on expert agreement. It was also felt that in neonates with cardiac disorders, levetiracetam may be the preferred second-line ASM. This was also based only on expert agreement. The third recommendation, I will talk about a little bit more, but what it was following cessation of acute provoked seizures without evidence for neonatal onset epilepsies, anti-seizure medications should be discontinued before discharge home, regardless of MRI or EEG findings. This was based on expert recommendations. The fourth one was that therapeutic hypothermia may reduce seizure burden in neonates with hypoxic ischemic encephalopathy. This was an evidence-based recommendation, but I'll address this a little bit more again. Now, treating neonatal seizures, electroclinical and electrographic only seizures, to achieve a lower seizure burden may be associated with improved outcome. This was expert agreement. And the 6th recommendation was that a trial of pyridoxine may be attempted in neonates presenting with clinical features of vitamin B6 dependent epilepsy and seizures unresponsive to second-line ASMs. This was expert agreement. Now, regarding the third recommendation, saying following cessation of acute provoked seizures without evidence for neonatal onset epilepsies, ASMs should be discontinued before discharge home, regardless of the MRI and EEG findings. I think this is too definitive a statement and all-encompassing. I think we should consider the etiology, the neurological status of the baby, the neuroimaging findings of the baby, and the EEG at discharge, and then tailor the decision regarding stopping anti-seizure medications before discharge. Reassessment at 4 to 12 weeks is reasonable in some cases. In the majority of cases, however, with asymptomatic seizures, we should be able to stop anti-seizure medication prior to discharge. And it is very important for all of us to avoid prolonged ASM therapy in infancy without good cause to continue. One of the things when you looked at this recommendation was also based on the paper from Glass et al. Published in JAMA in 2021, and where they recommend routine discontinuation of ASM after seizure resolution of acute symptomatic neonatal seizures prior to hospital discharge. Most of the time when they see there is no evidence of neonatal onset epilepsy, it is based on continuous EEG monitoring and not having seizures on that for different periods of time. But most places in the world, we don't have continuous EEG monitoring available to us. And therefore, I think we have to tailor the decision to the individual baby. An editorial regarding this particular paper where it suggests that commentates that we should proceed with caution and not just discontinue anti-seizure medications in all babies with neonatal seizures prior to discharge. And this editorial is by Volpe, that I'm sure anybody interested in neonatal neurology knows about, in the Journal of Neonatal Perinatal Medicine. And the discussion on this is quite, I agree with all the points that Volpe raises, and I think it's worth reading that paper. Now, there is also a meta-analysis predominantly from India, where they looked at levetiracetam versus phenobarbital for management of neonatal seizures and concluded that with the limitation of very low certainty evidence, the results of their review suggest that levetiracetam may be non-inferior to phenobarb for managing neonatal seizures. And considering a better safety profile and marginally better neurodevelopmental outcome in the short term, levetiracetam may be considered an initial choice for managing neonatal seizures. But the NeoLev study certainly shows that the phenobarb is a superior drug to levetiracetam if you are looking at getting a seizure-free period for 24 hours after a loading dose of either drug. This is also an interesting review where this illustration is quite useful to see. All those with the blue boxes here are medications we already use: phenobarbital, benzodiazepine, phenytoin, lidocaine, topiramate, lacosamide, and shows us where these drugs work, either the voltage-gated sodium channel, all these mentioned here, or the GABA receptor with phenobarb and benzodiazepine. But it also outlines drugs that are being tried, like bumetanide, the bumipamine, which act through influencing the sodium-potassium chloride receptor co-transporter ratios by blocking the sodium-potassium chloride co-transporter, telampanil, which works through the AMPA receptor, blockers of the BDNF and the TRKB pathway, which work through the KCC2 channels, drugs that influence glycolysis, drugs that work through the potassium channels, for example, esogabine and retigabine, that was in which clinical trials were undertaken, but these studies were stopped because of concerns regarding visual and skin discoloration and possible effects on vision. There are also CBD is being tried, at least in animal models, to see what effects it might have on seizures in the neonatal period and how useful it might be. Now, we looked at bumetanide on neonatal seizures. We undertook a systematic review of animal and human studies. And bumetanide is an inhibitor of the sodium-potassium chloride co-transporter and has been suggested an adjunct to phenobarbital for treating neonatal seizures. In our systematic review of animal and human studies, we found that the animal data suggests that bumetanide has inconsistent effects as an anti-seizure medication. It can have a pro-convulsant effect as well as an anti-convulsant effect in different models. The data from human studies are scarce and raise some concerns regarding ototoxicity when given with aminoglycosides. Small studies suggest maybe it is useful, but we need better studies and well-conducted studies in animal models of HIE and then RCTs in human models to see if either bumetanide or other cation chloride co-transporter modulating drugs may be useful for seizures in the neonate. Now, if you look at inborn errors of metabolism, the cumulative incidence of inborn errors of metabolism is quite low. However, 25% will present in the neonatal period, and about 40% will present with neonatal seizures. Early diagnosis is very important because some may have specific treatment options, and expanded newborn screening in some places picks up asymptomatic babies with inborn errors of metabolism. So we should be aware of the possibility of this and look for it when it is appropriate. Treatable metabolic causes for seizures in the neonatal period are uncommon. However, perturbances in calcium, magnesium, sugar, sodium should be looked for and treated because they may make seizures due to any cause worse in the neonatal period. Targeted therapies are important if you have a mutation in the sodium channel, and it looks like a Dravet syndrome associated presentation with a loss of function mutation in the sodium channel. Then you may consider stiripentol or fenfluramine early if your standard drugs are not working, and you may try and avoid sodium channel drugs. However, remember, sodium channel mutations presenting with DEEs in the neonatal period may also be due to SCN1A mutations, which may have a mixed effect on a gain of function, loss of function type of activity, and sodium channel drugs may be effective in those babies with mutations. And therefore, you should give a trial of sodium channel drugs if you're thinking it's a potassium channel mutation or sodium channel mutation. KCNT1 mutations, quinidine may be useful, but also fluoperitine is being explored to see if that's useful. PCDH19 mutations, ganoxolone may be useful. GRIN2A mutations, drugs that affect the excitatory pathways may be useful. GLUT1 mutations, ketogenic diet is the best drug to use. If you have tuberous sclerosis, then vigabatrin, early use of vigabatrin may be helpful. Surgery, if associated with cortical dysplasias, brain malformation disorders, and you think of the vitamin responsive seizures, specific diets, you have a urea cycle disorder, removal of toxic metabolites by dialysis might also be helpful. This is just a table outlining what you could use for specific DEEs with the metabolic disorders and genetic mutations identified. KCNTN1, the data on that has been mixed with larger studies, and if you pool the data on the different studies, and most case series reporting on quinidine in the neonatal period have not found it to be that effective. The neuroprotective strategies are important. The time window for start of therapy is important. The earlier, the better. Animal models even start before you have any problems. High doses are often needed. And it is important to remember, therapeutic hypothermia may affect the pharmacokinetics and pharmacodynamics of drugs. These are some reviews that might be useful to read. Therapeutic hypothermia in the Western world and in the high-income countries has come to stay. It's been shown to be beneficial. The ILE position paper says it is beneficial, and its report results in improved long-term outcome and reduced seizure burden. Moderate to severe HIE treated with therapeutic hypothermia may still have devastating sequelae in the babies, and therefore we do need to look at other options. But this paper has provoked a lot of discussion and has opened up the question of, is therapeutic hypothermia ideal to use for moderate and severe neonatal encephalopathies across all countries in the world? This is often called the HELIX trial, and I know some of you have been involved in this trial. And what it showed was that therapeutic hypothermia did not reduce the combined outcome of death or disability at 18 months after neonatal encephalopathy in low and middle income countries, but significantly increased death alone. And then came out a very strong conclusion saying it should not be offered as treatment for neonatal encephalopathy in low and middle income countries, even when tertiary neonatal care facilities are available. The second conclusion is hotly debated, and there are studies now being undertaken, and there are studies that are smaller studies and smaller reviews from countries involved in this study, which suggests that we may have to have further studies and better RCTs to decide one way or the other. In the context of the Helix trial, we thought we would do a review of one of the modalities that's been used for neuroprotective treatment in hypoxic ischemic encephalopathy, and this was magnesium sulfate. However, we found that the overall evidence around long-term neurodevelopmental outcomes when used with or without therapeutic hypothermia was scant, but there seemed to be low certainty evidence suggesting magnesium sulfate may improve in-hospital neurological outcomes without affecting mortality where therapeutic hypothermia is not offered. And it was not associated with increased risk of hypotension. Well-designed RCTs are needed in this area. There are a whole lot of drugs that people across the world are working on for promising, with regard to promising adjuvant strategies for neuroprotection in neonatal HIE. And this would be useful for neonatal seizures because HIE still remains the most common cause of seizures in the neonate. Prognosis and outcome prediction for babies with seizures in the neonatal period is very important. Etiology is important, clinical profile and history is important, blood tests, urine, CSF, metabolic studies are important. Genetic studies, if they're available to you, can often add very useful data. But when it is not available, the clinical profile, history, and what we can do with EEG and neuroimaging often helps you to prognosticate, because decisions may have to be made before you've got all your investigations back. And prevention of prematurity is small for gestational age, and good care antenatally, perinatally, and neonatally is very important. Etiology, we've already said, is important because it helps with treatment and prognostication. Accurate diagnosis is essential. If you have a mixed bag and you're treating babies with and without seizures, then your outcome data is very difficult to interpret. And anti-seizure medications are limited, and it's important to develop new ones, which and neuroprotective strategies we have to work on further. Targeted therapy is important. Prognostication and individualized options of care are essential. Supportive therapy, early interventional services are extremely important. And identifying the etiology not only helps the baby with seizures, but it also helps in family counseling and pre-pregnancy planning. Research is essential, as I'm sure all of us will agree, and more trials are needed with optimal models, locations, and trial design, and specific models for different gestational ages, etiologies, and clinical profile. We have to harness artificial intelligence. We are already using machine learning when we are looking at seizure detection programs and automated background analysis programs. There are many challenges in this area, but there have been many advances too, and we anticipate further ones, and therefore there's a lot of hope, not just hype, regarding new horizons in this area. Thank you.
Thank you, Professor Lakshmi, for amazing talk. And I think it's covered everything. Dr. Suresh, would you like to make any comments, please?
Thank you, Lakshmi. I think that was very comprehensive. You addressed all aspects of neonatal seizures and looking at the evidence. It's amazing, really, really well.
Except imaging, which is your area, isn't it?
Yeah, but yeah, I think you covered everything. I think the key messages were there, and I think we can always kind of refer to the couple of key papers, isn't it, as a reference for people to go away and have a look at. I think one of the challenges that we find are the ones where you have a structural kind of a cause for seizures, and they are in status, and how far do you go in kind of treating them? I think that's one very tricky issue, because you're not quite sure how far you want to go, because say, for example, we had a recent baby with a bleed, massive bleed, and they were in status. So at some point we had to kind of then say that, well, we're not going to chase the seizures here. Is that your experience as well? And you're gonna...
Yes, you start off being very as aggressive in your treatment. And then you sort of like say, okay, I'll only treat seizures longer than this duration, because you know there's a limit to how much you can support the baby as well. And I think that, yes, intracranial bleeds with preterm babies, that's often an issue because they can have status and it's quite difficult to treat. And often it's not picked up when it's well into the seizures because it doesn't occur early in the neonatal period. But also babies with structural abnormalities in the form of brain malformation disorders, where you have to have a very good radiologists to pick up subtle abnormalities in the other hemisphere. You see obvious abnormalities in one hemisphere and subtle abnormalities in the other hemisphere, and you have status coming from all over the place and multifocal seizures. You may have to decide to move towards comfort care. And it's a difficult decision to make, I agree. When we've had to make, it's always distressing for everybody concerned.
Dr. Lakshman, do you have some guidelines for this do not escalate kind of treatment when we have, because we are stuck. We don't have guidelines and it has to be individualized, and it really gets stuck in a very bad way for the family, and just trying to say, do not escalate treatment and go and do towards supportive, comfort, palliative kind of care. I mean, do you have guidelines established?
No, we don't. We do tailor it to the individual baby, but we always make sure that, especially if you're withdrawing care, there is a neurologist who's seeing the baby. The neonatologist and the neonatal team is very involved. Social worker is involved. We often try, the family obviously is very important in the decision making. And we often start quite early saying we are very worried, we're not sure what the baby's outcome's going to be like. Right now, we'll do all that we think we can do, but that but we're very concerned about outcome. So we start that conversation very early, because if you wait for too long, then the brainstem is very strong and the babies will survive, more likely to survive. So if you're going towards like palliative care in the neonatal period, and or towards like getting the best outcome for the baby and the family, then the decision regarding maybe stopping care, especially with symptomatic epilepsy, symptomatic seizures, has to be made fairly early. So we start the conversation, we don't say, we say, this is what we think we should do now, but we're very worried about outcome. And we start that very early in the process. And we use the EEG, we use the EEG quite a bit for prognostication.
Thank you, but we really need to have a diagnosis. We really need to have a diagnosis before we go slow, because for the next...
But we switch to comfort care even without a diagnosis. If we prognosticate that, our prognostication is that the outcome is very poor.
But if, but once if you're clear that there is no genetic etiology, because...
But even if there is a genetic etiology, you you may have to go to comfort care.
I'm just saying that, we at least somebody the child has to survive till you get all the things available for the diagnosis. You have taken the samples.
You mean in your situation you find
yeah, that's what I'm saying. So that's why you need to have a diagnosis. That's the way, and it becomes decision has to be taken when you're going to discontinue, so you should be able to say something for the next pregnancy. So I think maybe
you store the DNA, you get the parent's DNA, and
of course, yes. The only thing happens,
if the baby passes away, we try our best to also get some brain tissue if we can, in case there is a somatic mutation that you're not going to pick up on the blood.
Yeah, here we can do in tertiary centers, but many times, they are delivered outside, so that becomes a problem. Yeah. Dr. Suresh, one thing that you were there in India, then you went to Gosh. So anything changed in your...
No, I think
experience
what has changed
with neonatal seizures, in your experience, I'm saying.
I think we never used levetiracetam before, and we are using kind of levetiracetam more often. We use it as second line here. So phenobarbital is first line and levetiracetam as second line. The other kind of change I think we've seen is increasing trial of sodium channel blockers, because I think we now have better understanding of genetic epilepsies presenting in neonatal kind of period with seizures. I think if there is no obvious cause, and the seizures are not controlled with your phenobarbital and the levetiracetam, I would definitely give a phenytoin kind of challenge to kind of see whether that would work before we don't need any genetic diagnosis. I think that's more of a therapeutic challenge. That definitely has kind of changed, and we have subsequently in retrospect diagnosed a few cases with either KCNQ2 or SCN2A. So I think that's definitely one thing which we never did before. We were always very scared of giving kind of sodium channels blockers before. So I think that is another thing that has changed.
Yeah, I agree. And we've also had a couple of babies with KCNQ2. I've said give oxcarbazepine was having, Norton status was having a thing, and it seemed to work. And now there's lots of, this is a few years ago, but now there's more data coming, and we know the mechanism by which it works, and we use it a lot more. And even SCN1A mutations may respond to sodium channels when the seizures present in the neonatal period, because they're not as straightforward as the loss of function mutations that you see in Dravet syndrome.
Just the one last thing I wanted to mention is think of non-epileptic movements, because you can confuse. We recently had a child with hypereplexia who was being treated as a seizure. So just be mindful of non-epileptic abnormal movements in babies.
Hypereplexia certainly, and there are case reports of people treating it with multiple anti-seizure medications. But there are lots of other paroxysmal movements in neonates that are very easily mistaken for seizures. And even in the best of nurseries, and they even just benign neonatal sleep myoclonus, once you give an anti-seizure medication, you've often got the baby more sedated, and you see more movement. So you give another medication, and so it can escalate therapy. So you have to keep it in mind here.
I actually have a video of a baby who is in the back of the ambulance, and the paramedics are giving lorazepam, and basically this was benign sleep myoclonus and being treated as status.
No, I use it as an example. We have a baby that, this is now 10 years old, but the baby had got phenobarb, phenytoin, and clonazepam. By the time they got an AJ, it was benign neonatal sleep myoclonus. And this is in our own nursery, and we've got really good neonatologists. And this is not something that happens often, but it's sometimes difficult. And especially if they have diaphragmatic movements and they're getting a bit more sedated, and because with each anticonvulsant, then they have the occasional hypopnea, and they desaturate a bit. And so you add something more, and you have to be careful.
Dr. Vinay?
Yeah, nothing more to add. It's a very comprehensive talk, and covered all the details of the current understanding of neonatal seizures. The only thing is, for the people who are hearing this is just a beginning of the neonatal seizure story, and there are more to come, because the point here is, when we looked at from the ILA position paper, when we looked at the different types of seizures and the correlation with the etiology, there is not enough papers there. So many of these things, the so-called the expert consensus, are not definitely evidence-based. The focal clonic, as Lakshmi has clearly pointed out, that the focal clonic is with vascular. When it started as just vascular, then we finally, by the time the paper was written, we have to modify that. Should be a consistent focal clonic seizures, because otherwise, in a situation like India, I have burned my fingers, because much more it is common in infections, because the focal clonic seizures can go either way. It can come from one seizure, it can come from one side, and then the other focal clonic can come from the other side, and that's very common with rotavirus encephalopathy, paracavirus encephalopathy. So the point is, this kind of things, there are much more literature to come. These two papers from ILA are basically, it will work as a framework on which much more research will come, and then probably we'll be able to redo the whole thing in the next 5 years or so. That's what I see.
And even flip-flop seizures, like you saw that EEG, I can show you the same, a similar looking EEG with a baby with HIE. you can see, as Vinay is saying, you can see seizures that go from one hemisphere to the other. And when we looked at our electroclinical seizures, it was not a small percentage of babies with HIE in our data set who had flip-flop seizures within the same seizure that would go from left to right and back to the left, or just become bilateral afterwards. So I think a very important thing, I think, for all of us to remember is always to put all the information that you have at your command, or to put it together and not just take one little bit and work on and just make decisions on that, even though one little bit might look very dramatic.
Yeah, but I feel, I don't know whether you think like that or not, that in the last couple of years, because the genetics has come in a big way, so that is adding on. That has been something which is leading on, because you have precision medicine coming, and then you need it for genetic counseling for the future. So, we have had imaging and electro EEG and all for very long, but this genetics and all is bringing so much, new, in this area.
But to remember that the genetics are very important, but they still only, genetic epilepsies only constitute a small number of seizures in the neonate.
Absolutely.
Quite a few are self-resolving, that you may not even need to treat all of them. At least 30%, if you don't do anything, even with the KCNQ2, unless it's a DEE, you don't do anything, the seizures often stop. And I sometimes try and convince people, just wait, let's see what happens. And we see you're monitoring the baby, what's the hurry? Yeah. You're monitoring the baby in the NICU or high K unit. And I'm not talking about EG monitoring, I'm just saying clinical monitoring.
Dr. Patil, there's so many questions. Can you please take the questions and ask the speaker and the experts?
First of all, thank you, Professor Lakshmi, about that very informative talk. I will start with my question. You mentioned in your talk multiple times that continuous EEG is a gold standard. So I just wanted to know if you in your practice, if you suspect someone is having seizure, how long you record, how you annotate kind of clinical seizures, subclinical seizures, and how much importance do you give to particular thing like clinical or electrographic seizures?
I think a lot of clinical seizures are not seizures, except you're seeing the same thing. Only thing, I think if you have focal clonic all the time on one side doesn't change, then there's a stronger correlation that it may be arterial ischemic stroke on the opposite side. But otherwise, you have to be very careful. We've shown, lots of people have shown, Geraldine Boylan's group, several groups from the UK have shown that clinical acumen is not good. You can be the experienced neonatologist, you can be the neonatal fellow, you can be the nurse. The number of times you get correct with just clinical semiology is probably 50%. So you can toss a coin almost. So I don't think I try my best not to treat clinical seizures, but I think an EEG background is often useful, even if you can't do continuous EEG monitoring. So if you do a 1 hour recording, if your background is totally normal, then again, the chances are low. If you can continue, it's good to continue. But a lot of places can't. We can't. The only times we do continuous monitoring is for study, a research study. And then like here in our department, I take my long service leave and sit and analyze the data from it. So it's not easy in most places. But we use a combination of AEG. AEG is available to us. So we'll often do a conventional EEG for an hour. And then if you think, oh, this looks like a baby on the background and looks like a baby will have seizures, then we will continue monitoring. If you could, and leave it on for as long as we can. And so maybe 3 hours. If you don't get a seizure in 3 hours and your background's absolutely normal, chances of getting seizures become much, much, much lower. So we use a combination of things. So often in practice, even if the baby's having seizures, we'll do a 1 hour or 1.5 hour EEG, then put the AEG on and use that and the clinical to decide where we go with the anticonvulsant. We load, and then we'll do another conventional EEG the next morning. And that's what most of the time we do, but once a day. Sometimes I persuade to just leave the leads on and we'll reconnect in the, later in the evening if there are lots of seizures. So you have to tailor what you use to what you are able to use. Ideally, yes, we should all have continuous EEG monitoring. And that's why I think about the guidelines about saying, stop every baby with anti-seizure medication when they're discharged. It's based on having continuous EEG, conventional EEG monitoring to say there are no seizures. We know a lot of symptomatic seizures are electrographic only. So in some babies, it's a small percentage who continue to have seizures. These are mainly babies who've had severe infections like HSV or some other viral infection, some other viral infections, even bacterial infections, but also babies who had severe hypoglycemia are often the babies or very severe HIE who don't stop having seizures. And so I think it's very hard. I mean, yes, I like everyone to have continuous monitoring for high-risk babies? Yes. And I think we should all work towards trying to get that. We have to work towards having central EEG readers so that in a city, maybe you have one center where all the EEGs are read. It's possible. It's been done in the NeoLEF study. That people have done EEGs in New Zealand and America, in different states in America, and being able to centralize it. Takes a lot of effort and work, but we can at least start within our own states and see if we can centralize the EEG there and then sort of go forth. I keep saying, and there people say you can't use that, but if you think of ultrasounds and MRIs, we used to think ultrasounds are good enough in the neonatal period.
I think
Yes.
we lost her.
Yeah, she was.
Yeah, she's frozen.
Okay.
You can read the next question and
Should we? Yeah, we'll start
you
with the
can wait.
question and answers.
Yeah.
We're not
Yeah.
You can
Okay.
wait for a second.
Yeah.
monitoring.
It is coming.
I heard in
Yeah.
India it's much easier to have in the bigger cities.
Dr. Lakshmi, we lost you in the last
Yeah.
your
Oh,
audio and
sorry.
video in the last 1 minute, so you'll have to repeat it actually.
No, I'm saying I was just looking at Suresh and saying that, see, we only had ultrasounds previously for most of the time, but we now get MRIs in most babies, if not early, at least at discharge and preterm, at a time of discharge in preterm babies. So we have to think like that, and we have to think it is possible. It may take some time, but it needs all of us to advocate for it and talk to our hospitals, our health boards, our governments who provide the money for it. And we also have to work at I think in practice, we have to have centralized EEG reading if that's going to work for everyone. The rich hospital, private hospitals, maybe I hear from a lot of private hospitals in India that you're able to get continuous EEG monitoring. Is that correct?
Yeah. I think most of our tertiary hospital do have continuous EEG monitoring, and
But is it read in live? Like,
yeah, means it can be read live as well as after the EEG also it can be analyzed. So
Yeah, we also
Yeah.
do it in certain situations, not in all. In certain situations, we do put them on continuous, and then the resident intermittently goes and reads. I mean, it's not on the continuous monitoring tracking system that if you mean computerized, it's not in that way. But then we do put it for continuously for quite some time, as it is indicated. That is only a small subset. All of them we are doing only as what you suggested. We actually let the leads on, or we just say if you will do it in the morning, do it in the evening. I mean, like that. You just do it. That is how. And in between, although amplitude integrated EEG is there in our neonatal the NICU, but initially about a couple of years back it picked up, but now it's again not. I mean, it's done, but I mean, it's not. Not that followed. I mean, as protocol wise. I mean, you're doing like as a protocol. You're always doing it. I mean, we did do
all
it,
our
but like
at-risk babies get amplitude integrated EEG. Yeah,
no,
babies at risk for seizures or with encephalopathy.
Yeah. So here that thing initially it was there, but now it is sort of fizzled out a bit. Dr. Sandeep, there are lots of questions. Please fast.
Yeah. I think
Yeah,
we'll
we
start
have
with the question and answer.
we have 8 minutes, so please.
Yes.
And it's about 1:30 a.m. for Dr. Lakshmi. Please remember that.
No. I'm in Perth.
She's in
So
Perth.
it's close to midnight for me.
Oh, it's close to
midnight.
midnight.
Yeah,
Okay,
it's a
okay. So
midnight.
1 hour
Yeah.
less. So 1 hour better. Okay, ठीक है. It's okay. Yeah.
So the first question is, I think by Dr. Naresh Taide, are there any clinical markers to differentiate between primary neonatal epileptic encephalopathy group versus IM presenting with the encephalopathy, like a seizure-like presentation? Are there any clinical markers?
I think that's a difficult question, but I think the babies with the metabolic disorders who present with seizures are often encephalopathic. Whereas with some of the genetic epilepsies, they're not encephalopathic when they start the seizures, they become encephalopathic once the seizures start. So that is maybe one clue to it. And the metabolic, even your blood gases, your lactate in your blood gas, your sugar, all of that is abnormal in the metabolic perturbance or metabolic inborn error of metabolism. Whereas that's all often normal, at least initially, unless they go into status and have secondary problems with their metabolic profile in the babies with the genetic epilepsies. But you can have overlap. Yeah.
Okay. The second question is, which medicine is the best for rural area to treat neonatal seizures? I think the question,
Rural or city, I think phenobarb still has the greatest,
phenobarbital, yeah, I
highest
think
efficacy.
we all
It's
agree with that.
probably 95% of the world uses phenobarb as a first-line medication.
Yeah.
But to be cognizant that there are lots of funny movements in babies that are not epileptic seizures.
Okay.
Any
The next,
one sec. I'll just
yeah.
ask Dr. Lakshmi, any situation where you like to use levetiracetam first line?
I do. Like,
Any
see
situation,
the baby
yeah.
coming from far away and the person there is convinced it's a seizure, but the history is not suggestive. There's no markers for it. There's no perinatal asphyxia. There's nothing else. And these are movements. They'll try and send you a video, but you'll get a bit of a video. You can't make out what's happening. In which case, when I think they're not epileptic seizures, but they have to be transported by air or train or bus or something, because Western Australia, the state where I practice, is very huge. So we do a lot of telephone things about what in which case I might say give levetiracetam rather than phenobarb, because I'm not convinced it's a seizure, but it's difficult to convince the person at the other end of the line that it's not a seizure.
So my add-on question would be, you're given phenobarbital, you're given levetiracetam. Would you think to add on phenytoin at that point, or you'll wait? Because like we were talking about sodium channel blocker as a potential channelopathy.
Probably try a phenytoin, and if it's not like you don't need IV, then I might try just oxcarbazepine.
Okay.
Yeah, but if the child's not that sick but still having some seizures, but yeah, I would certainly, if you've tried two medications and they are epileptic seizures, I would consider phenytoin. But often, a lot of the time, midazolam is now being used a bit less, but our neonatologists used to like it very much. Even before they called us, they would have given levetiracetam and midazolam. But now it's changing.
The only situation in which we are a bit careful about phenytoin is we have a cardiac intensive care unit, and the babies who've had post-cardiac surgery or pericardiac bleeds or infarcts. And in those, we try and kind of avoid phenytoin just because of cardiac side effects. But even then, we've used, like, if you've done phenobarbital, levetiracetam, and then midazolam, and we've used it still. Most of them, there is no complication, but it is just because there is a potential for it causing arrhythmia, you're just a bit more cautious.
And it's the same is true of trying to use lidocaine if you've had a cardiac problem, because of the incidence of cardiac problems that may occur with that. But you can also, some parts of the world, they would go with lidocaine because they think if it was a cardiac problem, because even like between phenytoin and lidocaine, because if you look at the data on the studies which have used lidocaine as a second or third line drug, the efficacy as an add-on is better in those studies than phenytoin as a second line drug. The percentage of babies who've responded is higher. But we use lidocaine only after we've done probably phenytoin. we don't use it before we use phenytoin, and we're careful about phenytoin in situation where there's cardiac dysfunction. Even with severe HIE, you already have cardiac dysfunction.
Okay, I will just move on to the next question because there are quite a few questions now unanswered. So there is a question from Dr. Josna. She wanted to know about experience of using paraldehyde in neonatal seizures.
Very rarely, and the data is there's not been much literature on it either. And so and paraldehyde now for us is not available. It's not available in Australia. So I haven't used it for a decade, almost.
Okay, the next question is from Dr.
And
Bijal
there's very
Patel.
little data, so I would go with it.
Just on a treatment, this is a question from Dr. Patra, is about pyridoxine dependent seizures. How long we should continue pyridoxine? Is it lifelong?
I think so. It's, a small dose of pyridoxine is not very harmful to you. You can monitor any side effects that you need. And I would, if with my PDEs, I do.
But now you can do the genetic study.
Yeah, I'm saying if they
Prove it.
have a pyridoxine-dependent epilepsy and they have a PNPO or an antiquatin mutation, then I would continue. Yeah.
Yeah, better to know that.
Yeah, but I thought, sorry.
Do you monitor liver function for suppose someone is on antiquatin P5P and it actually has some evidence of hepatotoxicity for longer duration treatment.
Yes. Yeah, I mean, by then, see, you give it to confirm they've got the mutation, and if they don't, you try and get rid of it. But if they do, and keep it, but you don't have to give a huge dose. You can reduce the dose, and yes, you would monitor. But I have to say, I don't have anyone who's on pyridoxal phosphate in the long term. And so if anyone else has, please share your experience. I have babies with antiquatin deficiency that I've left on pyridoxine.
Okay, the next question is from Bangladesh, Dr. Hussein Khan. Quinidine is not available in Bangladesh, but probably available in India and Australia. What are its trade name in India and Australia? What is just a question about?
In Australia, I would just prescribe this as quinidine, and but I don't know the trade name in India. And somebody said at a recent meeting I was at that quinidine is not available in India right now.
No, it's not available.
It's not available.
It's not available. We got it
That's what somebody said. But the data, the little data there is on using quinidine with the KCNTN1 mutations for neonatal seizures is not very convincing that you have to try it at that time.
Yeah, I think it's the findings have not been replicated, isn't it?
That's right.
Most of the people, I mean, when we've used it, and you kind of yourself kind of said when you use that, it really doesn't work.
And if you look at all the case reports of in the neonatal period, it's again, there are hardly any that have said it's actually been. In fact, there are papers saying dextromethorphan is useful, antihistamine is useful, more case reports saying that than quinidine being useful.
Yeah, but actually we have been able to procure quinidine, but obviously it's not available in India. It has to be imported actually. I mean, yeah, you're right. In the neonatal.
We used it in 3-4 patients and then they're not at all.
And yes.
Yeah, it's not great. It's not a great drug. Because we got some 50%, 60% reduction immediately, but it's not a long term.
But Dr. Vinan, we did not do it in the first 28 days actually. We have must be one 2 months or something the age. So I mean that's why we did not have in the neonatal. So if neonatal is even worse, I mean not that good, so we don't know. Yeah. Dr. Patil.
Yeah.
Time is up.
So next question from Dr. Vikram Kumar. He's asking about apprehension with phenobarbital in animal studies promoting increased apoptosis.
Yes, totally agree.
What is your take? Yeah,
I think there is data showing that it increases apoptosis, but there's some data saying it doesn't. But I think we have to be very careful. People often quote the study by Farrell et al., where phenobarb was used for febrile convulsions. I don't think you can extrapolate that study to neonates, because in that they used it for 2 years, which is a much longer period than we are using it for a short term in the neonatal period. But there is certainly data saying that it affects neurodevelopmental outcome. It affects your histology, if you look at histopathology in the animal models, and may affect the hippocampal area, the synaptic density there. And so I think that we have to be careful. But there is also, I mean, people keep saying levetiracetam is a neuroprotective and doesn't have. I think it's too early to say that. I think we have to wait and see. There is animal data saying levetiracetam also increases in apoptosis, and especially at the equivalent doses to what we may be using in the NeoLAV3 study. And so I think we have to wait for long-term outcome data. The short-term outcome data is comforting, but I don't think we know for sure till we have long-term outcome data. So I think all anti-seizure medications, we have to be careful.
Okay, so the next question is from Dr. Mohammad Aslam Nagi from UAE. He's asking about role of topiramate in neonatal epileptic encephalopathies. Topiramate can be neuroprotective as well. So
I think it's a very good drug, and it would, if you had an IV preparation, you probably would be using it. You may even end up using it before phenobarb in the long term if you get one. But it is because of its mechanism of action, and also because of the data is again it suggests that it could be more neuroprotective than some of the other drugs that we've looked at or we use. And that's where the other medication, talampinil, is also being explored in the animal models to see if that might be a better drug, because it acts through the same mechanisms on the AMPA receptor and the KINase receptors.
Okay.
No, I think that it's a good question, and I think that I do use topiramate, but often after we've tried the IV drugs and they're not useful. The problem is how much to use, because the few studies that have looked at levels, it's difficult to get good levels. And so I often just give, and there are people who give 10 per kilogram as a loading dose and then go to about 3 milligrams per kilogram per day. I haven't done loading doses. I've just started at 3 per kilogram per day. And I think it's useful, but in acute situation when you're in, it's a bit difficult to use. And also the sprinkles get stuck in nasogastric tubes. So how you give them is a problem. So you have to crush a tablet and give small amount, 25 milligram tablet.
Yeah. Like Dr. Lakshmi, we have been giving loading. Yeah,
you
but we have to
good.
crush. Yeah, but with crushing, because we don't even have those granules in the
because there were some case reports of hyperammonemia even with that. So I don't, but that was just a case report. And most of the time, by the time I've used topiramate, they're almost 5 to 7 days old, because you've tried all the others.
Yeah, I would not have used in the first 1 week, of course not. Yeah, I mean, that would be the latter part of the first month, yeah.
Shefali, what dose do you use for loading?
I can just let you know 1 second.
Okay.
I'll just let you know 1 second. I'll just check and let you know. Yeah, 1 second. I've written in our neuropharmacopy also. We made a drug book for all the neurology related, pediatric neurology related drugs. So we're revising that and going to make into an app. So actually so I'll just let you know 1 second.
So I go with a very low dose. I go with a 2 milligram per kilogram just to be on the safer side. So bit twitchy with a higher dosage, around 5 chain.
The people who seem to have published a little in that area say load with 10 per kilogram and then give 3 per kilogram per day. But I've mostly just started with 3.
No, we do 5 in 2 days. Like we give 2 days 5. We've not given 10, but I'm just telling you 100%. It's 5 2 days, and then you start. You give the 2 days loading, not the 1 day one.
We use 5.
Yeah, 5 for 2 days. We use 5 for 2 days. I'm just checking also, but I use 5 for 2 days and then do. We've never given 10, but we give this 2 days loading. Yes, that we do.
I'll take next question meanwhile. So this is like a question from Dr. Richi Dalai. She's asking about as a ILA recommendation, anti-seizure medical duration, which mentions to stop anti-seizure medical medication at discharge regardless of MRI and EEG findings. So, okay, highly recommendation is about to stop anti-seizure medication at discharge regardless of MRI and EEG findings. Can it be done in all neonates, or is there any criteria to decide in whom we should stop?
The ILA recommendation suggests that you stop in all. This is based on the data on Hannah Glass's study paper, which was in JAMA, I think 2 years ago or so. But if you look at that paper, there are some concerns or in the number of babies in the different categories who came off anti-seizure. They pulled data from different centers, and the number of babies who came off anti-seizure medications and those who went home on anti-seizure medications, the long-term outcomes. So I think that we have to be cautious about extrapolating that and stopping every baby's anti-seizure medications. Most babies you can stop by the time of discharge, but there are some in whom you may wish to be a bit more conservative and leave the one anti-seizure medication instead of 4 that you needed to use to get on top of the seizures, depending on if you've got severe HIE. Your EEG shows lots of epileptiform discharges and shows lots of brief rhythmic discharges, then leave them on and reassess. I usually do it at 4 to 6 weeks. And but you can do it, people, Volpe suggests doing it at 1 to 3, waiting for 1 to 3 months and then making a call. And so I think that you have to use your head, I think you proceed. Don't just say, oh, everybody has to stop. But I think in the majority, we can stop and we should stop.
Okay. There is a question.
Yeah.
There's a question by Dr. Anita Sharma. This is a practical question. Whether you do HLA before giving carbamazepine in neonate.
No, I don't. If they if they're Huan Chinese in origin, I'm more careful than and may not use it at all till I get the HLA typing. But in others, we just give it. We don't test everybody except if they're from the Chinese province or Chinese origin. Because if you have the HLA phenotype from India, the chance of you getting a drug reaction is very low.
Yeah, agree.
Also, you don't want to spend time as well, isn't it? Because
That's
it's going
right.
to take time to get your HLA typing done.
Yeah.
Okay, so I think this is the last question for the evening by Dr. Rama Lakshmi. I think she's asking, can you please share your views on, I think, CFM or continuous EEG monitoring in a preterm, less than 28 weeks gestation babies, as there is limited evidence of EEG baseline data for this group?
I think it's a good question because it's very difficult. Getting EEG leads on, keeping them on with their fragile skin is sometimes a problem. But there is now emerging data. The thing is that I think continuous EEG, when are you going to monitor them? I think it's a bit hard because what happens is that I'm sure all of you have had instances where the first EEG looks good, baby looks good for the gestational age, and then but then has an intraventricular bleed in the first week and gets worse. So how long are you going to monitor? But I think and that's where I think serial EEGs are often helpful. And if the baby becomes encephalopathic, whereas it was not, then you should monitor continuously at that time. The preliminary data with AEG suggested that preterm babies have a lot of seizures in the soon after they're born. But when they actually did conventional EEG, they found that not all of them were seizures, and the incidence of seizures is much lower than we initially thought in the preterm babies in the first few days of life. But afterwards, end of week 1, week 2, they may get, and around time of big intraventricular hemorrhages and parenchymal hemorrhages, they often have prolonged seizures that are not picked up because unless you monitor, you may not pick them up. And they're more likely to be electrographic only seizures than even term babies. So question is a difficult question to answer, but there's data on EEG reporting that you can see. We ourselves have published guidelines to report on EEGs in less than 28 weekers. It's called CARF7, CARFS to the power of 7, because the S has got 7 things that are sensitivities, synchrony, asymmetry, sleep, sharp, size, patterns, and so on. So you're welcome to look it up and see if it's useful for you.
Okay, thank you. I think we answer most of the
Yeah,
queries?
Dr. Parekh, thank you so much. I will ask Dr. Parekh, Dr. Goraya, or anybody else from the SIG to make any comments. I know we are 12 minutes past, but in the last 1 or 2 minutes, and before I ask the speaker and the experts to give take-home message finally, and we wind up. Dr. Goraya.
Yeah, very excellent talk and very comprehensive talk covering practically all the aspects of management of neonatal seizures. I have a very brief question. Is there any particular reason for for our speaker? Is there any particular reason for choosing phenobarb over phenytoin, given that the first ever study showed almost equal efficacy? Number one. Number two, phenytoin has a broader spectrum in neonatal seizure, considering that it can cover all the channelopathies also at the same time. So it is not kind of associated with brain neurodevelopmental issues like apoptosis and other things. So other than just a kind of convention, is there any other reason that we don't choose phenytoin over phenobarb?
One, maybe there are more studies with phenobarb. Two, I think IV access in babies can be quite difficult. And, the extravasation syndromes with phenytoin can be quite nasty. And you just have to have one child with a hand which is purple and you're spending hours worrying about it, then you become much more careful using phenytoin. I think that, and cardiac in dysfunction is higher. And a lot of babies with severe HI, if you actually look, may have cardiac dysfunction. So I think that's some of the reasons for that. And the efficacy studies in the animal models probably more convincing for phenobarb than phenytoin, but there's literature about both.
Thank you.
And also the other thing I think is very difficult to keep. If you have a baby on phenytoin, you start and you think it works. To use phenytoin orally in a neonate is very difficult. Your blood levels will be like a yo-yo up and down. And the pharmacodynamics of liquid phenytoin are in some ways unstable. It's very hard to predict. So it's very hard to use as a regular medication in a neonate or early infancy. It's okay if you're able to use the tablets, the Infatabs or the capsules, but not the liquid. And every other drug seems to change it much more than some of the other drugs we use.
Okay, thank you. Thank you.
So fantastic talk, Professor Nagarajan, and very many new things for me as well. And just a small question. I know it cannot be answered in the time frame given, but what is the endpoint you usually consider for treating electroclinical seizures? So I mean, if they continue to be refractory, not electroclinical, but electrographic seizures. Okay, so if you have no clinical seizures, but the EEG continues to show electrographic seizures, you've also used phenobarbital coma, you've almost used everything, then what's the endpoint really?
Yes, it does occur that you finally say, okay, I cannot just continue doing that. So you then talk about one options of care if you're still ventilating. If you're not, then you start using all the other topiramate, your oxcarbazepine, the other drugs to see, and you just have to accept, and you can't continuously monitor. These babies probably do have electrographic seizures. If you continue to monitor, if you do it at 2 weeks, you will still find that it is very abnormal and that you capture electrographic seizures. So after first, I think the first 48, 72 hours quite aggressive with trying to get on top of everything, but then you start tailoring, looking at the whole baby rather than just the EEG.
Yeah.
I don't think you can say it's on day 4 that you will do it on day 5, but after you used IV phenobarb, IV phenytoin, IV midazolam, there are not that many. You could try IV lacosamide, but you're sort of getting less and less with your number of medications that you use. You would certainly use phenobarb and levetiracetam as at least 2 of the drugs that you would try. And I would probably also use phenytoin if I was in that situation, if the baby will tolerate it, before sort of saying, okay, now we'll do, keep it, get the best fit, where you're saying care rather than cure. You don't want the baby to, babies having clinical seizures is distressing for everybody. So you want to try and get on top of them. But if they're only electrographic, you stop doing EEGs.
Yeah, so it's more, So what I meant here was, would you like to continue abolishing all the electrographic seizures at some point in time, or you decide that it's okay now, the baby is in any case not responding for the electrographic seizures, and you decide to call everything up and continue with the minimum bare possible anti-epileptics? That's
Yeah, I agree that we should reduce the number of ASMs if it's not working. They're probably getting more adverse effects from it than any benefits from it at that stage. So you sort of minimize the number you have and start taking them off one by one so that you,
Thank you
and
so
end
much.
and stay with just one or two. Yeah.
Great talk. Thank you.
Thank you.
Thank you so much, Professor Lakshmi. It was so wonderful to hear you, and also the discussion, which has gone on a very practical point of view. Thank you so much. I'm Dr. Sujata Kanere.
Hello, nice to meet
you. Thank you. Ranjit, you want to say something before Dr. Lakshmi gives the final take home? Ranjit.
Okay. I think he's traveling.
It's okay then. I think Dr. Lakshmi, your final take home, then I'll ask Dr. Suresh and Dr. Vinay also to give one final message. When we can wind up. Yeah. Dr. Lakshmi, a final message.
Thank you very much. It's a pleasure to do the webinar and for all these questions. This is an area that I think there are advances in, and I hope we have better options for treatment of seizures in the next few years. But I think one of the things that we all need to remember is, one, under treatment of seizures is not good, neither is over treatment. So we need to try and diagnose accurately, or as accurately as we can, and differentiate between non-epileptic events and actually epileptic seizures, and use medications. I use them at good doses when I initially use them, but then I try and minimize the number of anti-seizure medications, even if the seizures are not under control over time. By about 5 to 7 days, unless you know it looks like a DEE, we've started taking off medications. And I think we have to watch this space. There are lots of new things coming.
Absolutely. And one thing more for practical from India and other low resource countries is decide to when to go palliative, and supportive care, because sometimes you spend so much of resources to ultimately prolong life and prolong stay ultimately and recommend a mortality or a very severe neurodevelopmental challenges later on. So with the thing that thing has to be kept in mind more. Dr. Suresh, you have had our experience and now you are resourced.
No, I don't think there is much difference between kind of resource rich or poor for neonatal seizures. I think the treatment modalities are the same and they are not that expensive, isn't it? So I think most people will have access to that. So the only kind of
Cinabab still is the cheapest drug.
Exactly. Yeah, exactly.
It is.
The only thing in addition to what Lakshmi said and I mentioned earlier is just think about sodium channel blockers, because that's a one kind of treatable condition or which can be controlled fairly easily with a simple treatment. So think of that. And otherwise, thank you for inviting. I think it was really excellent session. Thank you.
Thank you. Vinay?
Yeah, nothing more to add. As I told,
you have to give a message, Dr. Vinay. You have to give a message.
Yeah, okay.
Vinay's message.
I'll just echo what Lakshmi was telling, and I told it in the beginning. Don't take those ILA papers as the last word in neonatal seizures, and take that with the right
beginning of the story.
It's the beginning of the journey, like Casablanca's statement.
Middle of the journey. There's lots of literature from before as well.
Yeah. No, that what I'm telling is there is not more a classical epileptology approach was not given to neonatal seizures before, and now it is there, and then we have to look at all the seizures and then the etiology and the correlation. There are a lot of things which has to be identified and then move forward. But at this point in time, understand that the motto at this point is reduce the anti-seizure or anti-epileptic drug exposure as much as possible. So as Lakshmi rightly pointed out, identify the seizures, identify that it is an epileptic seizure as much as possible with the EEG, and then treat rather than treating blindly with anti-epileptic drugs, and try to come out of those anti-epileptic drugs as early as possible. So that is the message, I think, at this point.
Yeah.
And if we get a better drug, probably we'll continue treatment more and more. But at this point, earlier the better withdrawal, depending on the clinical situation.
Thank you. Thank you so much. And I'm really grateful to all of you for having spent
Good
so much
night.
time. And it's
you.
nearly, I mean, past midnight. Thank you so much. But all of
Thank
them
you,
will be
everyone.
available on YouTube for everyone. And thank you so much. We come back next week again for the next round for SIG. Thank you very much. Thank you all.
Bye-bye.
Thanks a lot.
Thank
Thank
you.
you.
Bye.
Good
Good
night.
night.
Bye.
Good night.
Good night.
Yeah.
Good night.
And thank you, Dr. Manisha.
Bye. Bye.